Thank you, Colin, and thanks everyone for being here today. It's really nice to be here. I got to present at this venue a couple of years ago as well, so it's always a pleasure to be talking with people who are supporting the peer worker community. So, as Colin mentioned, my name is Adrienne. I'm a psychologist. I kind of split my time between doing some clinical work at our academic medical center. And I also do a lot of community-based projects and programs and research related to the work of peer support specialists, peer recovery coaches, and community health workers. And I'm here to talk with you today about an initiative that we got funded by a grant-making foundation that involved developing some e-learning training modules that were specifically designed for peer specialists and community health workers and peer recovery coaches. So when we originally conceived of this project, it was actually kind of like the height of the COVID pandemic. It was like, May 2020 or something like that. And I was meeting with a group of community collaborators that I'd been working with for a long time. And we're thinking like, we need to pivot what we're doing to include more online learning. And, at the time, I'm sure you all remember, it was like a time when we didn't know if COVID would like ever end. It was one of those like scary times when we're like, is our future a remote work future? So we were thinking like, we wanted to create a training opportunity for peer specialists, peer recovery coaches, and community health workers that could be done in a self-paced remote way, like in a remote environment if need be, but also be incorporated into a live course if and when those came back. And so that's when we applied for this funding and got it. And we're thinking a lot about what a university's mandate really is. Like I work for a university, I work at an academic medical center, and we're thinking about like, what is a university's job as far as community education goes? Is our mandate really just to provide high quality education to people who are, paying our tuition and enrolled in our programs? Or do we have a broader responsibility to the community at large to think about like, how can we bring our knowledge out into the community in a way that makes sense? We looked at, what the mandate actually was for our university, and this is what it was posted on the website, that the mission is to serve the people of Michigan and the world through preeminence in creating, communicating, preserving, and applying knowledge, art, and academic values, and in developing leaders and citizens who will challenge the present and enrich the future. So, in reading that, we're like, yeah, we think that partnering with community organizations to provide some of this education to community health workers, peer support specialists, and allied professionals would really be within the university's mandate, so long as we really partnered with the communities that we were hoping to provide this to make sure that it was well aligned and that it wasn't kind of like one of these like ivory tower meets community type of initiatives in a boom and bust cycle that might not, ever really take root. So this was the project. Our university-based team received funding from a health-focused foundation. It's called the Michigan Health Endowment Fund, to develop and evaluate a series of e-learning modules to sustainably provide behavioral health training for community health workers, peer support specialists, and peer recovery coaches. And what we wanted to focus on in these e-learning modules was communication and engagement skills related to particular ways of working, motivational interviewing and behavioral activation. And I'm going to talk about those two in a bit. We used community engaged methods to design the curriculum, which I'll also talk about in a bit. And we housed the e-learning modules on the webpage of a community organization, which is MISHWA, the Michigan Community Health Worker Alliance. They have a lot of public-facing continuing education opportunities, and they even have like a learning management system website where all of these are stored. And so we partnered with MISHWA from the beginning to say, this is where the modules are going to live. This is going to be their home. Because like the last thing we wanted was just for them to live on some random website that nobody would ever look at again at the end of our project. And then at the end of our project, what we did was we kind of planned in advance, we will transfer ownership to the community, to MSHWA. So the University of Michigan would no longer own the modules and no longer be responsible for them. They would be transferred over formally to this community partner for sustainability purposes, you know, so that it wouldn't be one of those things where these modules fall into a black hole and are never seen again. So I've used the term community worker a couple of times, and I just wanted to specify exactly what I mean by that, especially since this is a peer-focused conference and not one focused on community health workers. So what do they have in common? PSSs and PRCs, or peer providers or peers, are typically understood here in Michigan and nationally as well to be people in recovery from a mental health or substance use challenge who are certified to support others with similar experiences. And at least in Michigan, typically found in safety net behavioral health settings like community mental health or VA. Community health workers are a bit different in terms of a workforce. It's a relatively new workforce in terms of recognition in Michigan, although it's not a new workforce globally. There have been community health workers on the scene since the dawn of time, really, but globally, you know, since like their heyday, like it really started in the 1960s in a global sense, where the thought was to take some of the medical tasks that were currently in the hands of only medical doctors and put them in the hands of community members. So in Michigan and nationally, community health workers are defined as trained frontline health workers who are trusted members of or closely connected to the population served. And here they typically work in safety net physical health settings like FQHCs or other health centers. So what do they have in common? They are different workforces in that you're much more likely to see a CHW in a health center, and you're much more likely to see a peer in community mental health. However, they do have one very important thing in common, which is the firsthand experiential knowledge of the community that they serve. And that's really what we try to draw upon in our work, to really think about like this is their strength, and this is what brings these two workforces together, is that experiential firsthand knowledge of the communities that they serve. The peer workforce has actually enjoyed financial sustainability in the mental health safety net in Michigan since I believe 2005, when peer credentialing and certification were established here. So the peer specialist and peer recovery coach financial sustainability piece is much older here than that of community health workers. The CHW workforce really reached that milestone only this year. In 2023, Michigan started looking at legislation that would enable financial sustainability of CHW through things like billing codes and things like that. But, you know, as of this year, both of these workforces are considered financially sustainable, or at least there are mechanisms in place to make them financially sustainable in various settings. So why should we work with a community advisory board? Like, you know, what's the point? Isn't it too much trouble? Shouldn't we just go ahead and design our modules and put them out there? Well, no, we felt like that would be kind of a risky and like a wrong-headed way to go about this. So we wanted to choose educational content that was truly applicable to the community. So we didn't want to create something that people would say, well, this doesn't really apply to me. And that's something that actually we knew about from what we understood. There had been both motivational interviewing and behavioral activation type trainings in the past, but a lot of the people who had gone to the trainings felt like they were really for clinicians and not for peers and not for community health workers, that they were very clinical in nature. And that even just the terms that were used were somewhat stigmatizing in a way that like, you know, like just peers just didn't talk that way. You know, they don't refer to their patients, for example. And that's kind of like the spirit of the way a lot of the trainings would go. We heard this anecdotally. So we wanted to do something different. We wanted it to be truly applicable to the peer work and peer scope of practice in our state. We also wanted to make sure we were choosing graphic design and language that matches the community and have it be like a natural fit. And we also wanted to build sustainability. So like, as I mentioned, Mishwa now kind of owns these modules. Mishwa is where they live. And we think that that is a far more sustainable approach than for us to kind of keep them here at the university. So we thought that working with a community advisory board would build sustainability into our project from the outset. And our work was really informed by the practice of community-based participatory research for health and action research and education frameworks. It's important to note that in Michigan, a minimum of a high school degree or GED is required to become a CHW or a peer. And so the pedagogy we're used to at the university might not apply. Like, we might not know how best to speak to the students who would be actually taking our course. So we had to make sure that on our community advisory board, we're serving peer specialists and community health workers actually on the board and telling us about how these modules would go over in the community. We also felt like, since disclosure and utilization of experiential knowledge was really important to both of these communities, we didn't want to tell people how to do that if we ourselves have never been in a position to do that. As a clinical psychologist, sometimes I do self-disclose. It's not something I'm like opposed to, but it's not part of my work in the same way that it is for a peer. And so we wanted to make sure that in this training, we were addressing this question of self-disclosure of experiential knowledge in an appropriate way. So these are just some of our community partners. We worked with Mishwa, as I mentioned. We also worked with an organization called Michigan Peer Specialists United, or MPSU. And you can learn more about these organizations from their website. I put the hyperlinks here. We also worked directly with MDHHS, the Michigan Department of Health and Human Services. They only recently began requiring continuing education for peer specialists. And so they have now continuing education standards, and we were able to apply for CE designation for these e-learning modules, and we're able to get them approved that way. But we did partner with the state from the beginning, because in Michigan, the state is who certifies peer specialists. Let me just check the chat, because I see there's a comment. Oh, never mind. It's just a thank you. Okay, so what did we focus on in these e-learning modules? One of our foci was motivational interviewing. So according to Miller and Rolnick, who are the people who originated this approach, motivational interviewing is a collaborative, goal-oriented style of communication with particular attention to the language of change. It is designed to strengthen personal motivation for and commitment to a specific goal by listening and exploring the person's own reason for change within an atmosphere of acceptance and compassion. So to me, this really speaks to peer scope of practice and peer values. I think that this really fits with the non-judgmental stance that is often emphasized. But, as I'll mention in a few minutes, like, I think that there's almost like an uneasy history or like an uneasy relationship between motivational interviewing and peer work. In fact, I heard from some people that it's regarded with some suspicion by certain peers. And what stood out to me was, like, I remembered when I first started working with peers when I was in the VA system around 2008, I think. I remember talking to some peer specialists who said, that's just manipulation. Motivational interviewing is just manipulation. That's all that is. So I was always kind of struck by this, like, wow, that's a really interesting take on what motivational interviewing is. And that always kind of stuck with me and informed the way that I really wanted to engage with the board to try to address what some of those concerns are and make it the case that we were not emphasizing any kind of manipulative communication. This is more information about MI from this website, motivationalinterviewing.org, which is a very helpful website if anyone wants to reference it. MI is a guiding style of communication that sits between following, which is good listening, and directing, which is giving information and advice. MI is designed to empower people to change by drawing out their own meaning, importance, and capacity for change. MI is based on a respectful and curious way of being with people that facilitates the natural process of change and honors client autonomy. We also emphasize behavioral activation in our e-learning modules. So this is a definition from AIMS. BA, or behavioral activation, is a brief evidence-based behavioral intervention for use in primary care, other healthcare, and community settings. BA teaches patients experiencing depressive or anxiety symptoms a set of skills to re-engage in valued life activities that they once found rewarding and enjoyable. So yes, this is not the most recovery-oriented statement, but like I think that it kind of captures like the nature of behavioral activation, which is really to try to reconnect people with valued activities that they maybe once had and somehow lost due to mental health concerns such as depression or anxiety. So what's interesting is that this AIMS Center here at UW, they really encourage both licensed and unlicensed providers to pursue training in brief evidence-based behavioral interventions that are well suited for primary care and medical settings, including behavioral activation. So their approach is like, yeah, like learning is good. Learning is good, and we want people to learn how to do evidence-based brief interventions, staying within scope. We don't want people out of scope, but we also know that we can provide these evidence-based trainings even to people who are not licensed, and that can include not licensed to provide psychotherapy, let's say. So that could include a peer specialist. It could include a medical assistant. There's a lot of entities, including UW, who are really trying to say, like, let's open up evidence-based practice to be more inclusive, staying in scope, not doing anything outside of scope, but at the same time, not like trapping these evidence-based practices within certain license types. So when we first started meeting and talking about MI and behavioral activation, we had a lot of interesting discussions with the CAB. So first of all, is motivational interviewing consistent with professional values? Like I had that in the back of my mind, like this comment from a peer specialist from so many years ago, oh, this is a form of manipulation. So do people think it's consistent with their professional values? Do people think the approaches are too clinical to fit with their usual practice? So we had lots of really interesting discussions about this on the CAB, thinking through it together, and thinking about how are we going to make these approaches like very approachable, very interesting to people, and useful to people who are within those peer specialists, peer recovery coach, or community health worker scope of practices. So on the CHW side, it was really interesting because their concerns are a little bit different from peers, because peers are used to, like, the mental health is their bread and butter. Like there's no entering mental health because they've been in mental health their whole careers or through their personal experience. For CHWs is different. Like they often got into the CHW practice because of their connection to a health center, or because they've been neighborhood advocates already for things like asthma or diabetes. So for them, we started to get into some of the literature around what are the situations that CHWs find themselves in. And what we found, and what the feedback was from the CAB, is that CHWs feel that they are thrust into complex interpersonal situations without the formal training that therapists receive. So they kind of find themselves in situations where somebody's crying or someone's depressed, and they're thinking like, okay, I know a lot about how to help someone make an asthma action plan, but I don't necessarily know what to do in this emotional situation. So there's one workforce development paper that quotes a CHW as saying ideal, sorry, I'm going to read the quote to you. 80% of the people I meet with end up crying at some point during our conversation. I deal with a lot of domestic violence issues, a lot of mental health issues, that I try to just at least be that first point of contact where they know it's okay and somebody's actually hearing me. So it's interesting because they they don't come at this from a perspective of they've been in the mental health space for so long. So their needs are a little bit different from those of peers who are just more naturally comfortable with the mental health space because that's who they are. Um, we also kind of ran into this question of like the word behavior and behavioral activation. So already people just had like these negative associations. Like they just like the word behavior was like not, it was almost like a trigger for people. They were like, I don't like it. They were like, I just think about people saying I have a bad behavior or this behavior is bad or drug use is a bad behavior. Or some of them were saying I associate it with behavioral control or behavior plans. So we were like, okay, we don't really need to use the word behavior in what we do. Let's call it an action plan because that's really all we're doing. Like it's an action plan. And everyone was kind of on board with the term goal setting and action planning instead of like inserting the word behavior that everyone felt negatively about. What we ended up doing was calling module 1 motivational interviewing and module 2 goal setting and action planning. And we felt like it went over a lot better in the community than if we had just called it behavioral activation, even though that was kind of the research base and the principles that we were using to develop the e-learning module. So this is where I want to pause actually and see if anyone wants to have a bit of a discussion here around peer providers and motivational interviewing. Like, I'm not as familiar with the space in California. I've worked in New York and Connecticut and Michigan, but not on the West Coast. So I don't know, like, are peers getting motivational interviewing training? How do they feel about it? Do they feel like it's helpful? Have you also heard, hey, this is just fancy manipulation? Out of curiosity, I would really love to know if anyone has encountered these views of MI, feeling positively, feeling negatively. Are peers trained in it already? To what extent is it in your curriculum? So if you would like to use the chat or unmute yourself and talk with me, I would really love to hear your experiences and ideas.
Yes, my name is Don Robinson, and I'm in peer support training. This is my this is my third peer support training that I participated in,
Uh-huh.
and I did get some education at the community college level as
Mm-hmm.
relates to addiction studies,
Mm-hmm.
and I am a person in recovery myself. So back to that question where it says motivational interviewing, what have you heard or experienced?
Yeah.
I've experienced that idea or the concept of motivational interviewing being a form of manipulation.
Uh-huh. Yeah.
I mean, I actually thought that myself, but I never
Uh-huh.
said it out loud because this is the first time I ever heard somebody say it other than
Uh-huh.
me thinking it. And I would call myself trying to trick a community member or somebody that I was working with to want to change by asking
Yeah.
certain kind of questions along the scope of motivational interviewing, but wording it in a way because I'm from the streets and since I'm dealing with a peer, well,
Yeah.
let me try to manipulate them into the idea of wanting to change.
Yeah.
For example, I would highlight the worstest part of my homelessness and drug abuse experiences
Yeah.
and go through the whole dramatic effect of it as I'm talking to them. And then at the same time, I would highlight how I overcame all that
Mm-hmm.
as a way to, I would do the real dramatic part as a way to manipulate them that you don't want to go down that tunnel.
Mm-hmm. Mm-hmm.
And then I would talk about my greatest accolades in recovery as a way that make them, well, not make them, but promote them or convince them why they might want to change, because here, this is
Mm-hmm.
how it will look if you did change. And I
Mm-hmm.
found some mixed views within the audience, like at a treatment center or an AA meeting. Some people would be kind of envious, so the
Uh-huh.
motivational interviewing didn't work in that way with
Uh-huh.
them. And then
Uh-huh.
others will come and say, man, I appreciate what you said. I really like what you said. What you said was really helpful to me. I'm happy for you. I'm proud of you. So now, well, that has been my experience. That has been my experience as it relates to that question.
Mm-hmm.
But
Mm-hmm.
am I, in a way, can be viewed as, oh, this guy trying to trick me. He trying to
Yeah.
manipulate me.
Yeah.
And then me, I know in my experience, I said to myself, well, let me try to motivational interview this guy by
Uh-huh.
telling him some stuff that
Uh-huh.
might kind of trick him into wanting to get some help.
Uh-huh.
That's all
Oh,
I wanted to say on that.
thank
Thank
you
you.
so much for saying this, because it is so consistent with what I've heard. It's not really in writing anywhere, right? It's not like you can look up an academic journal and find this, but I've heard it so many times from peers ever since that first time I heard it in the VA. And you're really confirming that it can feel like you're just trying to push someone toward something. Now, one of the people on our community advisory board was a peer who does a lot of MI trainings, and he was like, it's the opposite of manipulation. It's it's helping the person find within themselves what they really want and being on that journey with them. So, like, yes, you wouldn't motivationally interview someone to use more drugs. Like, that wouldn't make any sense. No one would ever do that. So, in that sense, yes, you do have your idea about what's better for the person, and you are trying to follow that, right? You wouldn't do MI for someone to get more depressed or use more drugs or use more alcohol. You do the opposite. So, in that sense, it's you using the skill toward a particular end. But in theory, it's that the person agrees that that's the better end too. And that you're helping the person find that internal intrinsic motivation to change, not because anyone else wants them to, not because their wife is trying to get them to, but because they want to for some reason. So you really put it perfectly, Mr. Robinson, and I appreciate your comments. I know Giselle and Sybil are also raising their hands, so I'm going to go with Giselle first, and we can continue the conversation.
Hi, Adrienne. Thank you for being here today. As far as motivational interviewing, myself, I'm a certified medical peer support specialist here in California. Full disclosure, I also work with CalMesa, the certifying entity, and I also volunteer at a recovery, over the influence recovery, which is a support program for moms that are in recovery. I am pursuing to be a drug and alcohol counselor, and that's how I got introduced to motivational interviewing through those classes.
Mhm.
And honestly, I love motivational interviewing. I obviously, with my own lived experience of substance use recovery and experience as a parent now, I have an adult son who is really struggling with that. And I tell you, the motivational interviewing it was really hard for me to apply it as a mom to my son,
Mhm.
but I think that it was incredible, the breakthroughs that I had with him, especially in comparison to how my parents talked to me when I was
Mhm.
in the peak of my addiction.
Mhm.
It was conversations of shame, of, my self-worth was questioned. Just everything about me was, I don't know. I was made to feel that I was really unworthy, that I was the worst of the worst because, I was using drugs and alcohol and I was a mom. And
Yeah.
so I tried really hard to use that and not, just kind of kill that stigma and tell my
Yeah.
son, and it all was motivational interviewing. And so I'm a fan of it. I also know that for California, it's something that CalMesa does put on the curriculum as a requirement. So we
Uh-huh.
do
Great.
ask that the curriculum cover basics of motivational interview, whether it's
Mhm.
ORs. So it's definitely something that we do want to include, which is why I joined this class, because I was like, oh,
Mhm.
I want to see what you have out there as
Mhm.
far as, because you're right, a lot of the motivational interviewing is clinical based.
Yeah.
And I even looked for motivational interviewing for parents and I couldn't find it. And I was
Oh,
thinking, I'm
maybe
going to
that's
do
our
a
next project.
no, no, don't take it from me. No, you can't. I was like, I'm going to create a handout for motivational interviewing, how to speak to your children, because
Yeah.
it's so important, instead of saying, what are you doing and why are you doing that, just to really use that skill. So
Yeah.
that's my personal experience with it. Thank you for letting me share.
Yeah, thank you. And I think if you wanted to do an MI for parents, like I think that is such a good idea. And like, maybe that could take the form of a book, but maybe that could take the form of something similar to what we did with the e-learning. And, hopefully by the end of this presentation, you'll have a sense of what approach we took, and you can see whether this is something you want to pursue as well. I was totally kidding. I'm not going to pursue this. This is for you. And I think
No,
that it
you
comes
can.
back, it comes back to
No,
that lived experience. Like, I
yes,
think
let's
that,
talk. I'm totally down to
yeah.
help,
So I'd be
because
happy to share our resources and just let you
thank
know how we
you.
did it, so that if you want to run with this, you can go for
I
it.
would love it. Thank you. I'll put my email in the chat.
Great. Um, I don't know if I'm pronouncing your name correctly. Is it Sybil or Sibyl?
It's Shabale, like a
Shabelle.
bale of
Okay,
hay.
apologies.
That's all right. It's tricksy on purpose. I haven't personally really experienced being trained in motivational interviewing or being engaged with it. And from what I'm gathering, correct me at any point,
Mhm.
things that I have been trained in are Socratic dialogue
Mhm.
and acceptance and commitment therapy. And I'm thinking particularly of the process that they call creative hopelessness,
Oh, yeah.
and engaging with people about what their reasons for being in a particular way are, and really getting at those underlying values, and then asking them to self-assess what the outcomes of those
Mhm.
things are, and being really careful to not be invested in
Mhm.
how they value those things. So
Mhm.
I feel like it really depends on who's doing the motivational interviewing. Are you
Yes.
invested in a particular outcome?
Yes.
Because if you are, you've tripped yourself already,
Yes.
is my
And
sense.
absolutely. And I think that can be so hard, because when
Mm,
you see someone in particular using substances and you see the consequences, you can't help
mhm,
but be a little, be like, well, I really wish for this person. But you have to catch yourself and be like, my job is more like to amplify whatever intrinsic motivation they have, and not insert myself into this, and not
mhm,
shame them, as Giselle was alluding to, and just be really non-judgmental and be listening so hard for those little signs of intrinsic motivation, and just be like an amplifier, you know?
mhm,
So I think it has a lot in common with that acceptance and commitment therapy, with that Socratic questioning. It has a
mhm.
lot of that in it.
Cool.
And I can share too, like, more resources about how to learn MI, because this presentation is really more about our process in creating these e-learning modules, and not so
Yeah,
much about the content. But I will tell you how to access the modules yourselves at the end, if that's of interest to you as well.
great. Yes, yes, please.
So I think what I'll do is I'll move on, and then I'll stop for questions in a bit. So here's just an example of what content we included. We had in module 1, it was the introduction. So it was understanding peers and CHWs, identifying the primary goals, understanding like what is ambivalence and why is ambivalence so important to this approach. Ambivalence is really like feeling two ways about something. That's what ambivalence is. Ambivalence is I can feel two opposite ways about something at the same time. I can want to stop using, and I can want to not stop using at the same time. And then module 2 is the basics. So what is change talk? So change talk is like one of these central ideas in motivational interviewing, and it's when somebody is talking like they're starting to think about changing. And then sustained talk is the opposite of that. It's when they're talking like they want to keep things the same. So in MI, you start to like just kind of ignore the sustained talk, like not shame it, but just kind of ignore it, and then really amplify the change talk. And then module 3 is the core skills. So open-ended questions, affirmations, reflective listening, and summaries. And that's usually understood with the acronym ORS. And then module 4 is kind of putting it all together and talking about the readiness ruler. And then there's a few like cute videos that we filmed of people demonstrating the skills. And I'll actually show you one of the videos. Then we, in the behavioral activation section, it's a goal setting and action planning. What is a SMART goal? Why set a long-term versus a short-term goal? And then understanding values and how they play into goals. And, you know, for those of you who are familiar with acceptance and commitment therapy, it was like very influenced by that with this values piece. So this is just a screenshot, and it's an example of what people see when they do our e-learning modules. So they kind of see pictures like this and a little like bullet point, like how much a person wants to change isn't a permanent aspect of their personality. And then, so this is kind of like an example of just informational pieces. And then as they click through, there's a voiceover talking to them. And, you know, you might get to a page like this, where stages of change. Tap or click on each arrow to learn about the stages of change. So they might click on a bottom arrow down here and it'll reveal like stage 1 is this, stage 2 is that. So there's some parts where you're just reading text and there's some parts where you're clicking on different parts and revealing stuff. Here's another example. So this is just static text. It's like, okay, what are some examples of open-ended questions? What do we even mean when we say, try to ask open-ended questions? So these are like examples. What do you make of that? What brings you here today? How does that make you feel? What would be the downside to that, instead of ones that are yes or no? Sometimes we're asking people to interact with the module. So this is where people are actually clicking the boxes and saying, which of these actually are open-ended questions? So the examples here are, what were the consequences for you? What would that be like for you? Did you feel bad about that? That one's not an open-ended question. That's closed-ended. Would that make you too anxious? That's closed-ended. It's just yes or no. Don't you think that was a bad idea? Also, no. And how did that make you feel? So they're supposed to be, you know, it's not rocket science, but it's like you're interacting a little bit with the module to say, like, trying to apply your knowledge. So here's a video demo. And before I play the video, I actually had better unshare my screen because I'm not sure if I shared it properly for a video. So I'm going to undo it and do it again. But I just want you to note before I show you the video that these are not professional actors. These are community members. They are real CHWs and peers. So, you know, it's not perfect from an acting point of view, but please forgive them because they're real people. So let me go back to my video. Hang on a second. Can someone unmute me and tell me if they can, not unmute me, unmute themselves and let me know if they can hear after I click play, because I don't want to play the whole thing if
I'll let you know.
Thank you so much.
In this video, you will see a series of conversations
Yeah.
between Tanya, a community worker, and Nicole, a person Tanya serves who struggles with loneliness and is having trouble leaving her house. You can picture Tanya as any type of community worker, whether that is a community health worker, a peer specialist, or a peer recovery coach. The focus of this video is following up on an action plan. You will see the same conversation happening in 2 different ways. One is not so effective, and one is effective. You will see that Tanya is guiding Nicole towards a SMART goal, a goal that is specific, measurable, achievable, relevant, and time-bound. Let's have a look.
Thanks for getting me all caught up on what's been going on for the past couple of weeks. It's nice to know where you're at with things. Last time we talked, we set up an action plan on going outside more. You said you would go to the senior center. Did you do that?
No, I didn't have time.
Well, you said you were going to make time. What happened?
I had a lot to do. I had bills to pay.
Paying bills took all day?
Well, no.
In this situation, Nicole feels bad about not meeting her goal from last time. Even if Tanya was trying to be friendly, she implies that Nicole did something wrong, which could make Nicole feel embarrassed. That could close off a follow-up conversation about the action plan. Let's see this conversation in a different way.
Thanks for getting me up to date on what's been going on for the past few weeks. It's good to know where you're at. Last time we talked, we set up an action plan on going outside more. You said you were going to go to the senior center. Were you able to do that?
No, I didn't. I didn't have time.
That's okay. It's all a part of the learning process. We learn a lot when we don't meet our goals right away. So let's learn together from this. What got in the way?
I've just been feeling down lately. Ever since my dog died, I just don't feel the same anymore. She was all I had after my husband passed. I would take her out for walks and go outside with her. I would even drive her around town with me and take her to the senior center. But now that there's no one to take care of,
Well, thanks for sharing that with me. Pets are like family. I actually had a cat that passed away not too long ago.
I'm sorry you lost your cat.
Thanks. I appreciate that. Now, can you tell me a little bit more about how you felt when you used to go outside with your dog?
They made me feel good. I wanted to go out because I knew it was good for her. Without her to take care of, I just go out when I have to go to the grocery store. By the time I do that, that's all the energy I have. So I get back home, I just do my own thing. I know I should do more. It's just hard.
Are there places you used to go with your dog that you might think about visiting again?
Well, she did really like going down to the senior center. My friends would bring their dogs too.
Okay, so let's review. Last time you said you were thinking about going outside more, but something got in the way and you were feeling down. Now, you said that your dog used to make you feel good about going out and your friends would bring their dogs to the senior center. Is that right so far?
Yeah,
Okay. Now, is going outside still a goal of yours?
yes it is.
Then we can keep working on it together. Let's discuss. Why is it a goal?
It's good for me. When I feel down, I don't go out, and that just makes things worse when I don't see anyone. My friends at the senior center, they're probably wondering what's going on with me.
Your friends are important to you and they care about you a lot, and you feel better when you go outside. But things are not feeling the same, and there's some barriers to that. Is that correct?
Yeah,
Maybe the goal we set up last time was too big. Can we think of a way to make a goal a little smaller about going outside instead of the senior center?
how about just going for a walk with one friend?
That sounds good. Who would you do that with?
Michelle, I guess. She called me last week.
Okay, and when do you want to do that?
Maybe every afternoon next week.
It would be great to do that. However, I don't want to set up a goal that's too big. How about we just do one day next week? And if you just so happen to go outside more, it's just extra.
Okay, that sounds better.
In this scene, Tanya has framed this situation as a learning opportunity instead of a failure. This gives Nicole the opportunity to reflect on how her action planning is going and see what adjustments are needed to make it work better. Tanya's technique allows Nicole to not feel embarrassed and instead work towards setting a new goal that will be a better fit. Tanya gently guides Nicole towards setting a SMART goal, a goal that is specific, measurable, achievable, relevant, and time-bound.
Okay, I'm gonna unshare and then share again so we can talk about it.
I think that was great acting.
I thought they were like pretty amazing given that they are not professionals. For some reason I can't see you guys anymore. Let me try this again. It's not working. Okay, one more try. Okay. Well, I can't see you guys anymore. Hopefully you can see my screen. I don't know why that happened. Let me get back to the slide that I was on. Okay. So in terms of the video, it was actually like so much fun to put together. You know, it was real CHWs and peers coming and doing those recordings. We had to do all the recordings outside because it was during COVID, which was somewhat unexpected because we didn't want the actors to have to wear masks during the video demonstrations. But it was great. And all of the videos are basically that short, and they kind of show like what to do and what not to do. So they kind of demonstrate like the anti-spirit of motivational interviewing and then the spirit of motivational interviewing, for example. That one was actually in the goal setting and action planning module, not motivational interviewing. And it was about what to do like when somebody sets a goal and then doesn't meet the goal. Like, how do you deal with that? So yeah, so then like after we actually finished the videos and embedded the modules and created them, then we had to evaluate our program to see, hey, is it working the way we think that it is? So we used this Kirkpatrick model of program evaluation, like reactions, learning, behavior, and results. I have a bunch of tables here that I'm going to show you. This is going into our article, so it's not like maybe super relevant to this group, but I just want to highlight a couple of things about the data. One thing is that from the beginning, there was a lot of agreement among participants that peer professionals should have both motivational interviewing and goal setting skills. So people basically agreed with us that that was the case. People generally liked both motivational interviewing and goal setting and action planning prior to the modules, but they liked it even more. They liked it 8% more afterwards. So that it increased, especially on the motivational interviewing side, their kind of affinity and their liking of it increased. In terms of professional values, respondents did think that both MI and goal setting and action planning were consistent with their profession's core values on the pre-survey. And these values did increase by about 5% or 4%, depending on, it was 5% for MI and 4% for action planning. And then on a 5-point frequency, which was from less than 1 time per year to daily, the average frequencies on the pre-survey was 3.5 for motivational interviewing and 3.4 for goal setting. The planned frequencies of use on the post-survey were higher, with plans to use motivational interviewing increasing by 17% and plans to use goal setting and action planning increasing by 24%. At 3 months, 23 participants completed another survey to assess the impact over time. All of our respondents reported having applied something that they learned from the modules to their work. So we were excited to see that our respondents were feeling like they were applying it to their work. They also reported feeling more prepared to use MI and goal setting after the modules. So there were some limitations to our program evaluation approach. Like, we really didn't evaluate learners like actual understanding or application of the skills. We weren't able to evaluate, hey, how good are our participants, our learners at motivational interviewing and goal setting. We had no way of evaluating that. So it was all basically self-reported. And only 26% of people like completed surveys at 3 months, which means the vast majority didn't complete it. And we don't know whether the majority of people were still using the skills. And, you know, another limitation, I guess, of the project overall is that these are relatively brief e-learning modules, and you can't really achieve competence at these approaches just from an e-learning module. You need supervision, you need ongoing training, you need more support than just this. So we did emphasize that in the training. And, you know, our community advisory board did feel that learners needed some fundamental information on these topics, which could kind of introduce them and like get their feet wet about the concepts, or potentially refresh their memory of past trainings, which would prepare them for more in-depth or on-the-job training in either one of the approaches. So for the acknowledgements, the project was made possible by a grant from the Michigan Health Endowment Fund. And the email address here is to the Michigan Community Health Worker Alliance, or MISHWA. And if anyone here wants access to the e-learning modules, Mishwa is who owns it now, and they're the ones to ask, like, hey, can a person from California actually do these modules? You know, do you have to live in Michigan to use them? I would love for you to be able to get access to them, even though you're in a different state. And I don't know like what their, you know, regulations are in terms of like people from elsewhere accessing them. But my hope is that it would be fine. I mean, as long as you're a CHW or a peer, it would be applicable to you. So that's Mishwa's education email address. There is a question in the chat. Are you going to be sharing the link or app? So yes, like if you want to get actual access to the modules, the person to ask would be this person at education@mishwa.org. I'm not 100% sure because of the across state thing, but I'm hopeful that it would work and you could get access to it. And in fact, I'll just give them a heads up that I did present to a California audience and it would be great to give them access. So if they're permitted, then it'll be possible. But I think these things can be useful. I'm going to quickly scroll through my references. These are kind of like, you know, the academic pieces of like where the information is coming from. And so you'll have access to this in my PowerPoint as well. But I wanted to end just by, I'm going to unshare my screen and talk with you more generally about the project, which is that like I do think that it's possible to create these collaborations with universities where kind of like the strengths of the community in combination with the strengths of a research university is possible. Like I think good things can happen when these types of collaborations happen. And I have to say, like our funder was great about this. Like our funder was just like, you know, one of these nonprofit foundations, like a grant making organization in our state. And they really saw the potential for this university community government partnership to come together and create these trainings. So I see Giselle has a question.
I was looking on the Mishwa site. They're not specifically advertising these.
They're not.
Okay, got
It's part
it.
of their CE offerings, and they
I
have a
see.
lot of CE offerings.
Got
So
it. So there's normally a charge for these. Is that what you're saying?
I actually don't know what they're going to do with it. You know, like
Okay.
it's like it'll be interesting to me what happens, like what's the future of these modules, because I
Got
think that
it.
they do charge like a small fee for some of their CE and then
Got
some
it.
not. So it just depends how they're going to decide to classify this.
Okay. I'll go ahead and email them. I'm doing the Cal Mesa training. Cal Mesa will be offering an 80-hour course as well. And so it'd be nice to, I don't know, maybe get some of videos or something to add to that, but we'll see.
Yeah, and this is far less, you know, this is something like 90 minutes of content total across 6 modules. So like much briefer than any
Right.
trainings you would get.
Right. Thank you.
Sure. Other questions or comments? Oh, Shabil?
I just want to say thank you. Thank you.
Oh, you're very welcome. Thanks for coming.
I wanted to just share that one of the greatest takeaways, and because I'm just a wordsy little person, using the term ambivalence, which I think in this case might even be better pronounced ambivalence, as in ambidextrous. Ambivalence as such a perfect word for describing what I feel like I strive for every day. You know, in my own recovery and in talking with people about theirs, is to hold those sort of opposing possibilities that are very relevant for myself or for somebody that I'm talking to in the same basket, being willing to hold things that want to repel each other, that seem oppositional in the same place, in the same moment that I'm having the conversation. And that is such a fabulous word for that.
I know. I think it's a great word too. And it captures so much about it. Like, you know, in some circumstances, people are truly forced into treatment. So that's a different case. But if somebody's there in front of you, mostly, it means there's at least some part that wants to change. And it's like there's kind of like a conflict or a battle inside of everybody, you know, like we all have something about ourselves we want to change and we're not. Like, I don't know anyone for whom that's not the case. And holding those two sides of ourselves and trying to helping someone else really explore the side of them that wants to change is what the approach is all about.
I think it's an excellent form of self-compassion.
Mm-hmm.
You know, that is something that feels really good for myself when I do it. And then when I extend that, especially to somebody maybe who isn't used to being held that way when they're talking about something that's important, and the way that becomes received is, it feels really good to have somebody recognize that actually all the power and the sovereignty lies with you, not me. Doesn't matter that I'm staff. Doesn't matter that XYZ. And I feel that's a really important part of what I do as a peer support worker. So thank you again.
Thank you. Anyone else want to unmute and share any ideas?
Yeah, I just wanted to say, after watching that video, those actors did pretty good.
Yeah.
But at the same time, I noticed, well, in my mind, I said when the consumer talked about their level of depression and not having the dog or the husband anymore, it seems like the worker was able to tap into that with empathy, concern, and genuine humility, and sharing their experience, which in turn acted as a form of manipulating the person motivational interviewing to want to do something different other than sit in their depression and take some action steps. So it's kind of like they I wouldn't say trick them, but they use techniques that, I don't know, that was just my take on it in a positive way. It was to me, in my mind, I said, oh, okay, that's an example of what I meant when I said trick them. But at the same time, it's am I convincing them to want to be motivated enough to the idea of what they can do to change their situation. And the supporter just nurtured it, developed it, reiterated it, supported it until the individual felt comfortable with the idea of action change for the results of getting out of the depressive state.
Yeah.
So I liked it. That's my comment on the video, because the video illustrated in a basic, non-professional acting way of how that would really look.
Yeah.
So it was perfect.
Thank you so much for that feedback. And I just want to highlight something that you're saying, which is important, which is that, like, yes, these folks are showing how you can move a conversation towards setting a goal. So that's what they're showing. What they're not showing is like sitting with the grief. You know, they're really not showing that. And I think you're absolutely right about that, that sometimes the massiveness of somebody's grief is that you don't want to be like, well, okay, let's set some goals now. Like,
right.
So, you know, it's, you know, sometimes that can feel almost like a little dismissive if you're really sitting with a person who's grieving. So I just want to say 100% agree with what you're saying. And I think that this shows an element of what can be done around setting goals and around listening to the person and listening to what they're saying and seeing what they really want and helping them change. But what it does not show is just acknowledging grief. And you know, I think that that's very true, and it's helpful feedback for us to hear.
And it didn't show a whole lot of ambivalence where the consumer was being combative or manipulative in their own way to not want to be encouraged to change. But that's okay. That's okay. That's okay. Because there is no cookie cutter anyway. But thank you, man. I appreciate it.
So we do, just like FYI, in another module, we have a somewhat more combative guide, and we show conversations that are going badly. And I ended up not showing it to you guys, but it's it's like maybe somewhat humorous, but it's kind of like, anyway, it's a guy who doesn't want to stop drinking, basically, is one of the videos, and he does get a bit more combative, and he rolls his eyes and he gets annoyed at the worker and stuff like that. So we have
Is the
another one that's
worker
a little bit more
is the
like
worker
that.
able to help him anyway?
So what we do is we show different versions of the conversation where it goes
Oh,
bad in some and it goes good in some.
okay.
So we kind of just show the different sides of how you can interact with someone. Like in this part of the story, the actor's showing someone who got a DUI, but is saying it had nothing to do with my drinking.
Oh, denial.
Yeah. So then it
Combative
shows like
denial.
ways that the worker is saying, like trying to like be judgmental and confront him, which doesn't work. And then trying a
Oh,
different way, which ends up working in the story. So it is a little artificial because, of course, it's more complicated in real life, but we're just trying to show some techniques in a brief way. So
well, thank you, man. I'm glad I came to this. See you
I'm
guys
glad that
later.
you're here too.